Time we come to this session, and you must be surprised to see all non-radiologists conducting this session. See, past one decade, what has changed? Why an intensivist are actually talking about radiology? Over the years, one revolution has changed the whole intensive care management, that is ultrasound. Fine? Past one decade, if I am not wrong, around in 2010, this modality was introduced, and you will find that not only in management in intensive care, but in emergency as well as physician-based management is now based on the imaging modality, especially ultrasound. Of course, there are new uses of conventional radiology, and little bit information of CT scan is also required. So at least even if I don't know what is being seen on the imaging, but I should know when I should, yeah. I think there was a problem in the, so in nutshell, we understand the importance of the radiology, and that to be understood by not only radiologist, but by an intensivist. As I introduced that ultrasound is one of the modality which has changed the scenario over the time. So today we are going to present some of the cases. Predominantly you will find that there is a use of ultrasound in most of the patients, but also we should not forget our old friends, that is conventional radiology and CT scan. So I introduce my panelist, that is Dr. Tarun, he is from Nasik, Rainbow. Dr. Tarun, please. Yeah, Dr. Abhijit, he is from Apollo, Mumbai. Dr. Rakshay is an ultrasonography specialist, he is from Rainbow, Bangalore. And Dr. Mona Shastri, she is from Surat. So with this introduction, we'll start with the cases. And first case, anybody, Dr. Mona, you can take this one. A 14-year-old female. And these are the actual cases. No modification has been done in the cases which we are going to present today. This is a 14-year-old. She was recovering from toxic shock syndrome, okay? And this was the 5th day of the patient. Patient was symptomatically normal. Patient was asymptomatic, and also afebrile. Urine output was quite okay. Child was coughing little bit, so somebody ordered an X-ray. Over investigations are usually done in most of the ICUs. So no.
Actually, X-ray.
I just want to have comment on this X-ray. What do you feel that this X-ray in an asymptomatic child, what do you feel?
Actually, X-ray chest is taken in supine position. So it shows cardiomegaly.
Is it audible to everybody?
Yeah.
Ma'am is audible? Okay.
I would like to, as the child is improving, it seems normal, but I would like to see PA view taken in proper position.
Okay, so you feel that clavicle is okay. There is a little bit cardiomegaly, fine. And there is fluid here, there, line position looks good, fine, you want to say? But
yeah.
Looking at the child, this looks like some AP view must have been taken in the ICU. So she wants some better view because now patient is shiftable to the radiology department. So patient was ultimately shifted to the radiology department, and the same X-ray, same patient after say 2 hours. Any comment, madam?
Yeah, so the X-ray is absolutely normal.
So there is no cardiomegaly and
no cardiomegaly. Both lung fields are clear. Even costophrenic angles are also clear.
Yeah. So this is very important that which view we are talking about. Can you elaborate, ma'am, what are the major differences between a PA and AP view? Means when we talk about intensive care, lying down patient.
So in PA view, we can see the clavicles more horizontal. Then scapula are out of lung fields. and the ribs are a little slanting. So the lung fields appear clear, while in AP and the heart size is normal, if it is not cardiomegaly then.
Okay.
And in AP view, the clavicles are oblique, ribs are horizontal, and the scapula are overlapping the lung fields.
So you mean to say major difference is of the cardiomegaly. Whenever there is a AP view,
And heart
everything will
appears
look
on
dilated.
yeah,
Fine.
Yeah.
So that is the major distortion which happens, and which is clinically also means we need to correlate a AP view clinically. Any point of difference from any panelist?
Most of the times, the common mistake which occurs in the ICU is that we take a AP view, and the most common problem which we face is the cardiomegaly. So whenever we have a cardiomegaly apparent on the AP view, we should always go for a PA view and confirm whether it is really there or not.
Okay. So we move to the next case. Septic shock is not an uncommon case which we get, and here you will find the use of different modality in a refractory shock. This is a patient, a 4-year-old, referred from some other hospital with refractory shock, came in emergency. Already 1 liter fluid has been given, 200 ml during transportation on dopamine, norepinephrine, epinephrine, vasopressin, steroid, and it is a real case. And patient looks like going to have an arrest. So when patient was brought in, we resecured the airway and put in the line, means we just reassured that line and infusions are fine. And look at the clinical situation of this patient. This patient had icy cold extremities, had tachycardia, low blood pressure. As you can see, blood pressure is just 47, and right internal jugular IJV is in place. So Dr. Rakshay, what do you feel that at this patient, at this place, if you were the clinician, what extra you could have done?
Yeah, so what we can see is whether to give more fluids, or you need to start some kind of vasopressor or anisotrope support, right? And that's always a challenge, that when a patient comes, initially it's pretty clear, you need to give fluid. But what we know is there are a lot of literature coming that if you give too much of fluids, that's harmful too. But what we need to understand though is when we talk about initial resuscitation, fluid resuscitation is important. But subsequently during stabilization phase, the commonest mistake which happened used to happen is every tachycardia, every drop in urine output, every drop in blood pressure, people end up giving fluid bolus. And what we clearly know is giving fluid bolus leads to a lot of fluid overload, and there are enough data to suggest that fluid overload is associated with mortality. So it becomes very important to figure out whether the treatment should be fluid bolus here or whether I should start a vasopressor support. So ultrasound I think is very helpful in this particular situation to make that judgment. Now the judgment, what we want information from ultrasound is if I give a fluid bolus, whether that's going to increase cardiac output. Now this is very important. The various ways of doing it, one is looking at IVC. The other option is looking at the heart itself and looking at the aortic velocity flow, change in inspiration and change in expiration. But the simplest thing probably is to looking at IVC.
So let's see what happened in the case, then we'll talk about what are the fallacies of this. Okay. Now, at this stage, I was very clear that next 10-15 minutes, this patient is going to have arrest. Fine. He was absolutely white. And to our surprise, when we put in probe on the heart, look at the cardiac contractility. What do you think, Dr. Rakshay? What is the type of cardiac contractility?
Yeah, so the image what you're seeing actually in the heart, it's almost like a long axis view. So what we are seeing is the left ventricle walls. What you're seeing is the intercostal septum, and then you're seeing the left free wall. They're almost touching each other. Now this is what we call as kissing ventricles. It's clear, at least looking at this image, you don't have to have great ultrasound skills, that you can make out from this image that the patient is preload deficient, that this patient would definitely benefit from a fluid bolus.
Okay, Dr. Abhijit, what do you feel that, look at the IVC, this is an IVC, fine, this is an M mode of IVC, and what do you feel that, what we are looking at?
So IVC assessment is now a very important tool in dynamic assessment of shock, and what we look at is basically IVC variability with respiration. So if it is a spontaneously breathing child, then we look at the IVC distensibility and collapsibility, and in positive pressure ventilation we look at distensibility. So if it is the variability is too high, it generally means there is a scope to give more fluids.
Okay, so what you see in this actual image, what you see? Means,
You can see the IVC
means
and
this is an IVC, this is
Yes.
an IVC, and since it is almost collapsed, it is a distensible.
Yes.
So probably this
There is
patient
scope to
can
give
be
more.
given more fluid.
Yes.
What we can draw? The
Yes.
interpretation on this patient. Okay, now let's see what happened. Okay, now just comment on the previous one. There are two heart of the same patient. This is before resuscitation and this one is after resuscitation. Can you make out the difference? There is a big amount of end diastolic volume in this one, B number. Okay. Now, if you put in a M mode, you can see the kissing ventricle, and here the kissing ventricle is not here. So, also look at the clinical. Patient CRT was more than 5 seconds, and here CRT was little bit better. I'll just take away the super added images. So clinical and radiological correlation should be there. At times, whenever there is a discrepancy, you should again review your case. Fine. So in this patient, we gave not only one bolus, over 1 hour we gave 6 fluid bolus. Who gave us the confidence? It is the imaging that gave us the confidence. Otherwise, clinically we would be fooled where we are going towards. So look at the first 1 hour, this 1 hour, end of 1 hour. The IVC you can compare, this is a distensible IVC and this is almost non-distensible IVC. Look at the blood pressure and point of monitoring. So again, this is one modality which can help. Dr. Rakshay, can you just convey us that what are the markers? I am going through the slides so that we can have visual impression what we see in the IVC.
Yeah, I think a couple of things I would add. I mean,
Yeah.
when a patient comes to emergency room, is in shock, and oftentimes, the reflex action to say I should give fluid bolus, because oftentimes it's septic shock what we see. But, it's not very easy to differentiate a septic shock from, say, a myocarditis or a cardiogenic shock. So the initial role for echo is to actually identify what kind of shock it is. Am I dealing with a septic shock? Am I dealing with a cardiogenic shock? I mean, though we say clinically, look at liver size, look at crepitations, we all know that, these are fine in theory points, but actually very difficult at the bedside. To see, you have pneumonia, liver is normally pushed down, you tend to be tachycardic, you tend to be febrile. If you have pneumonia, you hear crepitations. So it becomes very difficult to differentiate what kind of shock you're dealing with. So there, differentiating between a cardiac and a non-cardiac shock, I think it's very helpful. Now you have put a slide here about spontaneously breathing patient and using IVC. Now the problem with this is more than telling about fluid responsiveness, in a spontaneously breathing patient, the role of IVC is more like, say, CVP. It just tells you about roughly a CVP, and I know the CVP has fallen out of favor, people don't use CVP that much, but what is the importance about CVP is that extreme values are still very helpful. So if you have CVP very low, patient would respond to a fluid bolus. If CVP is very high, the patient is not going to respond to a fluid bolus. In the same manner, you can actually use IVC for a spontaneous breathing patient. If you see an IVC completely collapsed, I mean, that patient is likely to benefit from a fluid bolus. If you see an IVC is completely full, that patient is not going to actually benefit from fluid bolus rather than seeing a variation in a spontaneous breathing patient.
Can I interfere here? Suppose patient is breathing very fast, he is having respiratory distress. Then the distensibility of IVC is more important than collapsibility. If patient is having good distensible IVC despite of respiratory distress.
Yeah, so that's a problem. I mean, the IVC variation, what we are going to see in spontaneously breathing patient is not just relying only on the fluid status. It also depends upon the negative pressure you are creating while spontaneously breathing. So if someone is asthmatic or someone is severely acidotic, he is likely to have a collapsible IVC. Because of the breathing efforts, they're going to cause a huge swing. So that is why I think extreme values are more useful than looking at a variation in spontaneously breathing patient. Okay. And these parameters are more described for that reason in a ventilated patient where you can control the tidal volume you're giving. So in these kind of patients who are not ventilated, I would just see the extreme values like you would see in JVP, like you see in CVP. Now we can see here, in the first image you have an IVC which is completely full. So even this patient is spontaneously breathing, I would not give a fluid bolus no matter how his breathing efforts are. Whereas other side, IVC is completely collapsed and it's more likely that patient would respond to a fluid bolus rather than looking at a particular value and going through calculations. Those calculations are fine, but I think from bedside point of view, none of us probably spend time calculating, but look at those images visually and you can kind of make a decision. in a spontaneously breathing patient whether to give a fluid bolus or not. But if you're ventilated, you have far more control. So the point here is you're looking at a cardiopulmonary interaction to make your judgment. You're giving a dose of intrathoracic pressure variation by giving around 8 ml per kg tidal volume, and you're seeing that if I give 8 ml per kg tidal volume, what is the variation I'm seeing in IVC? So whether I'm going to use a distensibility index or it probably does not matter. There are parameters described, it's more than 12% variation or 18% variation I see, then this patient is likely to respond to fluid bolus.
So very important is what you summarized, that patient should be on controlled ventilation only, then comment on IVC. That is probably the most important message which you got to give. It is the easiest measure, but I've seen fellows just looking at the IVC giving fluid. It has to be patient first, IVC and other parameter. Can you means?
It's an important point. I just want to add. I mean, what happens here is, even if we were to do ultrasound in us, our IVC is likely to be collapsed. That does not mean that we are depleted and we need a fluid bolus. The question here is, you have a patient who has a poor cardiac output, and I want to know if I give a fluid bolus, patient is going to respond or not. In that context, that IVC variation becomes very important. Otherwise, every normal patient has, a normal individual has an IVC variation.
Dr. Tarun wants to say something?
Yeah, especially in resource limited settings.
Can be a little bit closer?
Yeah, especially in resource limited settings, what the USG gives us an advantage is like an extension of our clinical skills. So I would rather say that USG is just a part of your clinical exam. So you have to see the patient in entirety and then go for and then take a decision whether to give fluids or take a step up the inotrope.
Yeah, many times it happens. Some cardiologists would come, would do a probe, say IVC is collapsed, give a fluid bolus and goes off. And then people just land up giving a fluid bolus. So it's important.
Nothing is gold standard. It is the patient and clinical plus ultrasonological correlation, and again response to the fluid bolus is important. Now we move to the next case. Okay. Now look at this 2-year-old case of polytrauma. Patient is in ICU for 15 days. 2 CTs has been done, including brain CT scan, and past 6 days we found that there is a persistence of pneumothorax. Fine. So every time we put in a tube, pneumothorax was persisting. Now, Dr. Mona, just I want to ask you that already patient 2 CT scan, lot of radiation has been done. Now, how we can go better at this stage in this given patient? Anything else we can do?
Yes, sir. Simply taking a lateral view of chest, we can find out the exact location of tube, location of any loculated pneumothorax.
So what madam said is that get a lateral view. This is an old view, but definitely it is useful in ICU. And what we could see that anteriorly the pneumothorax is persisting. Agreed, ma'am?
Yes, sir. Yeah.
Okay.
There is a loculated pneumothorax anteriorly, and we can put the ICD tube in the loculated pneumothorax for drainage of air.
So we can direct our tube towards the anterior side. The same thing was done, and you can see the persistence of pneumothorax here, and that got relieved when we directed our tube. So we should not forget our old friends with the new modalities, and X-ray is still gold standard. And just remember, this is a lateral view, and these are the 2 areas, retrosternal clear area and retrocardiac, and this is the heart. In fact, nowadays, if you ask your radiologist, they have also forgotten the lateral view, how to interpret the new generation radiologists. They feel that ultrasonology and CT scan fetch up them money, so it is of waste. We often get lateral view in our ICU. Now we move to the next situation.
Excuse
this is
me, sir.
Dr. Mona.
Sir,
okay,
yeah.
ma'am.
So, see, if we are not in position to move the child, we can take cross-shoot lateral view. That is also our old chest X-ray, which chest lateral view.
Yeah. Now, this is another child. Dr. Mona, please, a 10-year-old with respiratory distress and is a semi-recumbent position patient, and this X-ray was brought to us. Do you feel that this X-ray is sufficient to give an answer?
Sir, actually, there is elevation of right dome, but I think the position of patient is oblique position, and a little bit lordotic type of view is there. So I would like to see the X-ray with proper position.
Yeah. So diaphragm are not very clear, and the whole axis looks very rotated or distorted. Fine. So totally agree with you, ma'am.
Right, sir.
Can you comment on this type of X-ray is taken when patient is lying on a semi-recumbent?
No, sir.
So this type of distortion happens, and in this given patient, it was actually semi-recumbent lordotic view. Fine. And what happens? It distorts the whole heart and the lung position, including diaphragm. And this is not uncommon when we don't touch the patient. We don't ask him to completely lie down or stand. Done?
In fact,
Now,
this is a good view to take and look at apices and even hilum. This lordotic view is good for them.
yeah. Previously, it used to be for the apexis and the hilum, and when we used to define the hilum. Now, Dr. Tarun, can you comment on the tube position, endotracheal tube position in the both X-rays?
Yeah. So on the first view, the tube is definitely slightly on the upper side, but the second X-ray is definitely showing the tube is high up. It should be actually just above the carina, and so we have to be very sure where the tube is, plus the position of the neck when the X-ray was taken. So both sides the tube appears to be slightly on the higher side. So we have to see the position of the carina, and in relation to that, we have to see where the tube is.
So what is the ideal position? Where should be the endotracheal
Around
tube?
1.5 to 2 centimeters above the carina in an older child.
Okay, suppose if you are not able to locate the carina,
Yeah.
is there any way to locate the carina?
Yes, we can do it on the X-ray. We can draw two axes actually. The first axis is the one which connects the vertebrae and points the position of the trachea, and the second is in the around the axis of the arch of aorta, and that actually will give us the intersection of the point of the two axes will actually give us the point of the carina.
Okay, thank you, sir. It's a D point. We call it D point. You just draw a straight line and bisect your aortic knob by 45 degree, and then you will find that where the bisection has happened, that is actually the carina. So you can locate the carina if it is not visible and then define. Now, Dr. Rakshay, this is a 12-year-old female, and it was a post H1N1. Done. Patient was with us with almost a fistula on the right side. Lot of air coming, lot of tubes inside. Now, on the 10th day, what we found that patient has become more toxic, and here instead of black, that is pneumothorax, it has become white. Okay. So, what do you feel that what has happened in this child?
Yeah, so I mean, so it looks like there is evidence of necrotizing pneumonia, right? So one of the complications we see with the H1N1, and one of the issues with H1N1 is that MRSA pneumonias are common as a part of secondary complication. So looks like the child is developing complications of necrotizing pneumonia with empyema. That's what it probably appears.
So you feel that patient has now developed empyema sort of thing, some effusion, maybe empyema or maybe syn pneumonia,
Could be.
simple
Could be
effusion.
fluid also.
What do you feel that means? I'm not sitting at Gangaram Hospital, I'm sitting at periphery, fine. So what else can I do? Should I shift the patient to CT scan, or can I do something at the bedside?
Yeah, so couple of
Even UAG chest can be used at bedside, and that can definitely help us to look at what is the kind of fluid, are there any adhesions to locate, so it can be used at bedside.
What do you feel, Dr. Abhijit, by your experience, how useful is the ultrasound modality to define the loculations and the septate?
Yeah, absolutely. If it is a symptomatic effusion, we see very clear transparent fluid.
Can you a little bit near?
But if we have adhesions or if there are septates which are not moving, then there is a chance of empyema there. And this looks like a complicated pneumonia and it's a secondary infection.
So which modality you feel is better? Is a CT scan or lung ultrasound to define the type of septate? Anybody?
UAG.
Both actually.
Yeah, so I think to add to what Abhijit is saying, I mean, one of the issues here is whether I should put a chest drain. If I put a chest drain, if I'm going to get a fluid, is it a septate which is very thin, which can be broken by fibrinolytics, or it is already formed a very thick peel which need VATs? And I think the definition of collection about the type of septate ultrasound can give you a great information. But if you want to know more about lungs and whether the extent of necrosis, a CT with contrast would be helpful. But in this case, certainly there's a huge advantage of doing an ultrasound because you need to take a call at that whether I'm supposed to put a chest drain now, should I give a fibrinolytics? That information, I think ultrasound will be very useful.
So it is a combination of imaging like X-ray, CT scan and ultrasound is going to help us. And of course, if you ask your surgeon to take the patient to theater, he will require CT scan. He won't go just for the ultrasound and he will require. But You know, what is the problem with the CT scan? Of course, there's a radiation. There's a lot of radiation is there. But if you want to define the pulmonary parenchyma and the lung pleural effusion and pleural thickness, then definitely CT scan helps. Also, the type of perfusion of the pleura, CT scan helps. But type of loculation is helped by your ultrasound. And good point about ultrasound is you can do twice or thrice a day yourself. That is the main benefit of ultrasound. I'll go through the case briefly. Now, in this patient, what we did CT scan. As you can see, this is a necrotizing pneumonia, and we knew that this was a patient of necrotizing pneumonia, so CT scan didn't added anything. And what we are able to see, this is a whiteness. Whiteness is again which we were able to see on the X-ray. So CT scan actually didn't help us in these type of patients very much. And now look at the ultrasound. If you look at the ultrasound, this is a normal effusion, is a black hypoechoic, and look at the effusion air, and already tube is in place. So do you all agree with me that putting more tube or fibrinolytic, is it going to help this patient? Probably no. Look at the effusion. There are loculations are not moving with the respiration at all. So this patient actually going to require VATS. This type of information we try to provide to everybody, that over the time, ultrasound is a modality which decides what type of intervention should be done along with the previous CT scan, as CT scan cannot be repeated on day-to-day basis. Fine? Agree, Dr. Akshay? Agree? All panelists agree? So we have got 13 minutes, so we switch over to the another patient. Dr. Abhijit, look at this 12-month-old baby with acute bronchiolitis, with respiratory distress and pneumothorax. Ultrasound was not available at this center. Here the pneumothorax was suspected. What else can we do?
You can take a lateral decubitus X-ray, put him in for 5 minutes, and then take X-ray. With that, you can show a pneumothorax more clearly.
In fact, Dr. Mona was also suggesting the same thing, doctor, and we took a right upper decubitus view, and that can define the air better way. So still conventional radiology has its own place in ICU. We should not forget our old friends. And now, suppose ultrasound is available to us, okay? Dr. Abhijit, again you can comment on this X-ray case of bronchiolitis, relatively stable, as you can see, 96 saturation, patient on CPAP, not in much distress. Can you comment on the X-ray?
On the left side, we can see a line.
I will enlarge it.
And this looks like pneumothorax there.
So, it looks like there is a straight line.
Yes.
Fine. And anything about the position of the X-ray?
It is not a well centralized X-ray, but there is some amount of push to the right side.
Okay, so it is not well centralized X-ray. There is a little bit pushing. Now, what we can do extra in this patient?
We can do a bedside UAG and confirm if there is pneumothorax.
Okay, so again the role of ultrasound. Look at the ultrasound. This is the actual picture of the ultrasound in this given patient. What do you feel? What is this suggestive of?
This is on M mode, and we can see there that this is a seashore sign absent. So we can see a complete horizontal lines, which is suggestive of pneumothorax.
Dr. Tarun, you agree with?
It's actually...
Okay. Can we show the normal, this was the normal X-ray, this was another X-ray done on the same patient, this was normal. I just want to have comment on this ultrasound lung sliding M mode. What it shows?
It shows the normal position of the pleura and the lungs. So over here we can see that there's a C, that the upper part is there, and the shore. So these are correlating well, and is it moving that well? So we see that it's moving well. So it looks like a normal ultrasonography.
Okay, so if you find a sand-like appearance on the M mode and a wave-like appearance on the chest wall, this is something so known as seashore sign. Again, want to emphasize, if you believe me and take our experience, past 20-21 years in intensive care, the simplistic thing on earth which we can do is ultrasound lung. Means a person of a mediocre caliber can also understand what is happening in the ultrasound lung after 10 to 15 scan. Do you agree with Dr. Me? Dr. Akshay is involved in...
I think I agree with you. I mean, ultrasound lung especially is a very simple structure.
Yeah.
Very few things to learn. And like you said, I think if you do 10 scans, you probably would learn. I mean, what is it you want to see in the lung ultrasound? The first two things what you have to identify.
Okay, can you elaborate this? I've shown the two pictures, A and B.
Yeah.
I just want that, just focus on. And today, given the slide, you will understand, okay, how simple is that. Can you explain the A, this part, and this line?
Yeah. So I think if you see an image, so how do you do lung ultrasound? I mean, you would take a probe and keep it vertically with a pointer pointing towards the head. Once you do that, first thing you need to identify is identify a rib. And rib being a bone, it won't transmit ultrasound. So you would see completely black behind it. So what you're seeing there is a rib. First identify rib, very important. Whatever is a white line which extends between two ribs, that is a pleura. And it's very important that this white line has to be on the undersurface of rib. Otherwise, if you have subcutaneous emphysema, you might think it is a pleura. So it's really important to identify that line. And if you see the first image, what Dr. Dhiren has actually marked, what you observe that line which is between two ribs, and you can see that as some ants are crawling along that line. There is some amount of shimmering, some amount of lightning happening on that line. What does that suggest? That suggests that the two pleuras are actually sliding. Very important that they are sliding. Now look at the second image. You can see two ribs again, and we identify this white line again, a pleura. And what we are seeing there is absolutely no shimmering, no movement at all. So which means the pleura is not sliding between two surfaces. So this is very important.
So everybody is convinced. Look at the two X-rays, two images.
Yeah. So those two are important things. So we are seeing there is no lung sliding. Now what we know is the air will not allow ultrasound beam to pass through. So what would that mean is every time an ultrasound beam normally hits a lung surface, pleura, it gets reflected back. And then it creates an artifact of a pleura underneath the pleural surface. So you keep what we call as A lines. So if there is, what happens in normal lung is, you would see a lung sliding and you would see multiple horizontal lines like pleura, what we call as A lines. When pneumothorax, what would happen is, you would see a lung which is not sliding and with multiple A lines. Now this presence of A lines is important. What that means is, if there is any fluid in the lung, you would see vertical lines, what we call as B lines. So if you feel that there is no lung sliding, but if you find even one B line, one vertical line, that rules out a possibility of pneumothorax, because now ultrasound beam has actually penetrated the lungs. So because if there is a pneumothorax, there is air between two pleura, you should only see A lines and absent pleural
Just last
sliding.
point on the pneumothorax. Can you comment on this?
Yeah, I mean barcode again, I personally find, and a lot of current studies say, they're a bit unreliable, because sometimes what happens is when you have asthma or a bronchiolitis, hyperinflated lung.
But still in some of the, for the starter, if you find, normally you find seashore like this, but if you find a straight line, so probably that indicates that this is air. So again, it is a clinical correlation in the given situation, and ultrasound is going to help. And go and attend a workshop, and I just believe me, it is the easiest thing, that is the ultrasound lung, which is going to help you. I think this much information, this much you can say message should be sufficient, because going into the detail, there are many if and buts, and later on you will find that you can be fooled by just looking at the ultrasound.
Yeah, I mean, I think the skill very important to learn is identifying lung sliding. Because that, if you are able to learn lung sliding, that is very useful.
I put up a slide.
Yeah.
Can you just comment on this?
So now let's imagine, now the big problem is, now the problem with lung ultrasound in identifying pneumothorax is extraordinarily sensitive. So sensitive to the point that it might not be clinically relevant. So you might identify such a trivial pneumothorax, and you might not know what to do with that pneumothorax. So you can't see it in the chest X-ray, right?
So in this image, look at, this is moving and this is not moving.
So that's why I think identifying a lung point is very important for us to identify the extent of pneumothorax. And it's one of the very specific signs for pneumothorax. So how do I do it? I keep the lung ultrasound probe around third or fourth intercostal space for a supine patient, because that is the most anterior part of the chest. If you identify absent lung point and multiple absent lung sliding and multiple A lines, there is a pneumothorax. And then I move the probe laterally.